Okay, thank you very much. My name is Dana Hilt. I'm Chief Medical Officer of Actinogen. Actinogen is focused singularly on developing a new chemical entity, a novel drug, Xanamem, which is a novel pro-cognitive and potentially disease-modifying drug that actually can be broadly applied to a number of different conditions that have cognitive impairment. It also has a very solid logic for the potential treatment of depression. So I'm going to tell you about two phase 2 trials that are presently underway in depression and Alzheimer's disease, with a readout in depression in mid-2024, about 6 months from now, and then an initial evaluation, an interim analysis of the Alzheimer's disease study in 25. So this is an oral once-a-day treatment, and essentially this is blocking cortisol production in the brain without systemically affecting cortisol or endocrine balance systemically. And it does it by being a specific isoform 1 inhibitor of 11-beta-HSD. It's brain penetrant, reduces brain cortisol, as I mentioned, without upsetting systemic endocrine balance. And we've shown in 2 normal volunteer studies, which I don't have time to go over in detail, which are on our website. It has a cognitive enhancing in attention, working memory, executive function in normal subjects. And also, I'm going to show you the results of a sub-analysis of an AD trial where it also had positive cognitive and, in fact, indications of clinical benefit. So this drug could be both a symptom-enhancing, symptomatic drug for cognitive impairment, but also a disease-modifying drug in Alzheimer's disease, and it may well have antidepressant effects. Secondarily, it has anti-inflammatory effects, and it may actually have insulin sensitization effects. This has been documented with this class of molecules in the literature. So there are a number of different activities which this drug could have which could be beneficial. We think in this class of a drug, this particular isoform 1 inhibitor, this drug is the only drug which shows excellent CNS penetration and target engagement. This particular study is in press now, be coming out in a few months, and this is a PET scanning study. Won't go into the details, but basically at low doses, 5, 10, and 20 milligrams a day of Xanamem, we can show that we have excellent target occupation and target engagement in the central nervous system. So this then allows us to take doses of 5 and 10 milligrams into longer-term trials to see if we have benefit. The 2 indications we're initially studying in phase 2 are depression, cognitive impairment associated with depression, and Alzheimer's disease. These are, needless to say, large markets, and there's always room for new therapy in these two diseases. The first one is depression. That's an ongoing study, and that will be reading out, as I said, in mid-2024, 160 patients. So we started a larger 9-month study in Alzheimer's disease in 220 patients. This is not MCI. This is in mild, moderate Alzheimer's disease with a mini-mental status of 18 to 24 and a CDR deficit and a cognition deficit. So first of all, go back to depression. What's the logic for treating patients with depression with this type of drug? Different studies vary, but 70 to 90% of patients with MDD report neurocognitive symptoms and have demonstrable objective decrease in cognition. Elevated cortisol is associated with significant and severe depression, and there's a variety of epidemiologic data, including the failure biochemically of failure of ACTH suppression with exogenous corticosteroid administration in patients with depression. So from many different perspectives and angles, treatment of patients with MDD to decrease brain cortisol has a logic to it. This is the ongoing trial, a readout in the middle of the year. It's a 6-week parallel design trial with 10 milligrams of Xanamem versus placebo. The patients have MDD, they have a cognitive deficit, and they have a persistent HAM-D depression, residual depression. We'll also be looking, as a primary endpoint, will be cognition. The secondary endpoint will be a separate determination of depression, the MADRS scale, as well as supplemental cognitive assessments. This study is being conducted now in Australia and the UK. Now, secondarily, if we look at Alzheimer's disease, and as you know, and I'm not going to get into too much detail, the therapies that have been approved or are under study in amyloid certainly are producing a clinical benefit in patients with Alzheimer's disease, but they're not curative by any means. And in fact, clearing amyloid quantitatively produces a very modest benefit. Shown here, if one looks at the dashed line, which is a placebo progression, exemplified in the Xanamem trial, for example. If you look at that, the solid line, that's the slowing of the progression in the AD patients or the MCI patients with a monoclonal antibody to amyloid. The area between those two curves is basically the therapeutic effect. This up here is the unmet medical need, okay? So you can see that quantitatively clearing amyloid has a pretty modest effect. And John Hardy, the father of this whole amyloid hypothesis, has actually said in print, he doesn't really understand this, why this is the case, that you get this modest effect. This suggests that there is a need for additional modalities for the treatment of patients with Alzheimer's disease. This is a quote from Howard Hilt, that basically his observation is that the majority of drugs now in development for Alzheimer's disease are approaching this unmet medical need. This is a non-amyloid, non-tau mechanism that must be at play in these patients. And this drug, Xanamem, is in fact one of those. So if you look at the epidemiology data in Alzheimer's disease, you see it's a pretty strong case that, the biggest risk factor on a population basis for Alzheimer's disease is actually depression. And patients with elevated cortisol and AD have a higher rate of developing AD and have a faster rate of progression. Individuals with the APOE4 allele have higher CSF cortisol levels, and higher plasma cortisol, just as a cross-sectional assessment measure, leads to a greater risk of developing AD. And so therefore, there's a pretty substantial epidemiologic case to be made that cortisol may play a role in sensitizing patient to a more aggressive form of AD, more rapid progression. Now, this slide is a little busy, and I won't go into all of the details of this slide. These slides are made available to you after this talk. But basically, this drug is going to decrease the cortisol production in the central nervous system with no effect on plasma cortisol long term. This isoform is also expressed in liver. And we think, in fact, that this has been demonstrated previously, that there is an effect on insulin-degrading enzyme and improving insulin sensitivity in patients receiving this type of medication. So there are a number of different biochemical, physiologic effects that have been shown in preclinical models in this column and in clinical results to date. These overall lead to the outcomes shown in purple on the right. Better attention, working memory, and executive function. There's a case to be made that there's a decreased rate of neurodegeneration and progression in Alzheimer's disease, and I'll show you some of those data, and potential metabolic benefits. Now, this drug had been previously studied in a phase 2 trial in 185 patients a few years ago. The eligibility criterion for that trial was a clinical diagnosis of Alzheimer's disease. There were no biomarker qualifications. One knows that even if you go to the very best centers, the NIA Alzheimer's Disease Center, the rate of false positive diagnosis based on clinical alone is anywhere from 30 to 50%. So what we did was we went back and we looked at patients who had retained plasma samples. There were 72 of those. We measured p-tau 181 in those patients, and then we broke them into two groups, those with elevated p-tau 181 and those without elevated p-tau 181. And we asked the question, does the drug have an effect in those patients with elevated p-tau 181? Those patients have Alzheimer's disease, number one. Number two, those patients are more likely to progress rapidly over a shorter interval of observation. So there's a chance then to see a clinical benefit in a short observation period. And so when we look at those data shown here, in the solid line is the patients on placebo. This is the high p-tau group. Placebo patients over 3 months have that degree of progression. And the blue line is the degree of progression in the patients in the high p-tau group that were treated with a drug. This is approximately 34 patients' data. this didn't reach statistical significance, but only because of the modest sample size. If one extends this to a year or a year and a half, you can see that there would be a very large treatment effect. So this type of data from this trial was the data which we developed design for the phase 2 trial that's now ongoing. I'll tell you about in a few minutes. So these are the clinical benefits. Do we see any cognitive benefits? The answer is yes. If we again look in the high p-tau group, what we see is a stabilization of cognition in the patients on Xanamem, and we see in the patients with placebo, you get a progression in loss of cognition over the observation period. Now, interestingly, in the low p-tau group, which are sort of closer to normal individuals, one sees an enhancement of cognition in the patients treated with Xanamem, and no enhancement in placebo. So we have two sets of data or benefits. We have a clinical benefit, and we have a cognitive benefit in this group of patients, the high p-tau patients. And so that's then the basis for the design of the study that's now ongoing. And the study is a parallel design study of 10 milligrams versus placebo. Now, we're enrolling patients not with MCI, but with mild, moderate Alzheimer's disease. So this is patients with a mini-mental status of 18 to 26. They have to have a cognitive deficit, and they have elevated p-tau 181. The primary endpoint here is cognition, and the secondary endpoint, two important secondary endpoints are functional measures, the CDR sum of boxes, and the Amsterdam IADL, which is a very nice scale for patients at a higher level of function. Now, the way we're going to be conducting this trial is we're going to enroll the first 100 patients in Australia, and then we'll be doing an interim analysis and then extend the study globally to the United States and probably to Europe. The FDA has already looked at this protocol and commented on it, and we're set to go. We could do this study in a number of different areas. And so, in summary then, if we look at where Xanamem is in development, and I haven't had time to go over the safety and tolerability, but it's now been given to approximately 300 subjects, normal subjects, and in patients with Alzheimer's disease and in a major depressive disorder. It is safe and well tolerated. There actually have not been any drug-associated serious adverse events in the program to date that have been attributable to the drug. It shows pro-cognitive effects in 3 separate trials, 2 normal volunteer studies and a study in Alzheimer's disease. And it's now in 2 phase 2 trials, as I've indicated. The ongoing trial with major depressive disorder will be reading out in mid-2024 in approximately June-July timeframe. And then trials recently started in Alzheimer's disease in patients with mild, moderate disease, and that's going to be 220 patients. And the projected readout for that trial will be, the interim analysis will be in the first half of 25. So we have 2 relatively near-term readouts. We have mid-2024 for depression, first half of 2025 for the Alzheimer's disease. And so I think that then is where we stand with Xanamem, which is a novel way to basically impede or decrease brain cortisol without having a systemic endocrine effect. So I want to thank you and happy to take any questions you have.